The first thing you should do is reflect both sternocleidomastoid muscles from their attachment to the sternum and the clavicle. And we had already done that on the right side, so I've just done that on the left side. Also, from one of your thoracic dissections, you had actually exposed and hinged this upper portion of the sternum and cut some of the ribs so that you could turn this back superiorly and get some exposure to the large main arteries coming off the aortic arch, the superior mediastinum. So what we're going to do is just complete that separation of this bony piece, which includes part of the sternum, first ribs, and a little bit of the clavicle as a block of tissue. To do that, you need to blunt dissect both from above, blunt dissecting down to start to detach the infrahyoid muscles from their attachment to the sternum, and turning this superiorly, do more blunt dissection to complete that process. Okay. This will allow us to get into not only the anterior triangle, but also make it a little bit easier to see some difficult structures that bridge from the upper thorax into the neck. To continue with the deep dissection of the neck, we've switched over to the left side in order to find the thoracic duct. For orientation, this is the sternocleidomastoid. You're going to turn that back. And the strap muscles that we talked about are more towards the midline. Key relationships here would be the internal jugular vein as it meets the left subclavian vein to form the left brachiocephalic vein, continuing across the superior mediastinum. This is another vein that's a transverse cervical vein. So what you want to do to find the thoracic duct is look at the junction of the internal jugular vein with the left subclavian and forming the left brachiocephalic. And to do that, you want to work medial to the internal jugular vein and dissect in this area. You usually find a very large prominent vein called the vertebral vein that I'm showing with the probe, and that's a tributary into this complex right here, this junctional complex. In this particular specimen, the thoracic duct is seen as a thin, almost whitish band. It's a vessel, but collapsed vessel. Normally, you'll see dried blood in this portion of the thoracic duct because the embalming process forces blood back into the first valve of the thoracic duct. In this specimen, it's empty, and that would make it a little bit more challenging to find. To confirm that you have the thoracic duct, you need to go back to the posterior mediastinum, relocate the thoracic duct, and sort of gently tug on it to confirm the continuity. Also, what I've done here to be a little more convincing is to flip the vessels back superiorly to find this little strand that looks nothing like but connective tissue here, terminating directly into, in this case, the left subclavian vein. So this structure is the thoracic duct. We'll not see one of these structures on the right side. Now we're going to look at the muscles in the deep neck dissection that are associated with the styloid process. For orientation, this is the posterior belly of the digastric. I'm going to reflect that posteriorly. And we see some branches of the external carotid artery I'll come back to in just a moment. But I want to focus on the muscle tissue that you see deep in the side of the head. And there's a relatively, at least compared to these three, superficial muscle that I'm showing here called the stylohyoid muscle. That more or less parallels the posterior belly of the digastric. It comes from the styloid process. Another muscle coming from the styloid process, I am holding in the forceps right here. That is going to the tongue from the styloid process, so this is the styloglossus. Then the deepest of the three muscles that are arising from the styloid process is right here, going from the styloid process to the pharynx. So this is the stylopharyngeus muscle. And then underneath it, on its lateral side, will be curving around a nerve. Pull that out here. And this nerve is the ninth cranial nerve, the glossopharyngeal nerve. So you need to see those three muscles and the associated glossopharyngeal nerve. Keep in mind, glossopharyngeal nerve only innervates one of those muscles, the stylopharyngeus. In terms of the branches of the external carotid artery, come back down here to identify the common carotid artery and its bifurcation into external branch and internal branch. and a slight swelling in this region usually demarcates the carotid sinus, right at the junction or the end of the common carotid and the beginning of the external and internal. So I'm going to trace the external carotid artery, which is coming up like this, and its branches. Typically, one of the first branches descends from its origin off the external carotid and heads down towards the thyroid gland. This is the superior thyroid artery. The next artery, typically, that comes off the external carotid travels medially and almost in a horizontal position and fairly deeply. This is the lingual artery heading to the tongue. Usually above that, but occasionally with a common trunk with the lingual artery, is a much longer artery called the facial artery that curls around in the submandibular triangle before crossing the margin of the mandible to end up in the face. So this branch is the facial artery. And both the lingual and the facial take their origin and course anteriorly off of the external carotid. A large artery comes off the posterior side of the external carotid artery, and the key landmark or relationship for identifying it is to note the 12th cranial nerve that you've identified before. Relocate that, and the occipital artery takes its origin from the external carotid right at the point where the 12th cranial nerve hooks around the artery from posterior to anterior. So that's just the occipital artery. Also down deep in this area between the external and the internal carotid artery, and I'm going to need to push the occipital artery out of the way, is a slender artery that ascends almost vertically. That is the ascending pharyngeal artery. It comes off of the external carotid in somewhat more variable position than the others. In this specimen, it's coming off real close to the bifurcation of common carotid. So here's the occipital again, external I'm tracing up. Here's the external continuing this way. And there's a branch, the two terminal branch. I'll show those first and then go back and get the last artery. Here's the external carotid coming into its bifurcation into its two terminal branches. Superficial temporal, which goes into the side of the head, and the maxillary artery that you've already dissected in the infratemporal fossa. And another branch, I think maybe I have broken off here, is coursing from the external carotid and into this other end of the stump is right here. This is the posterior auricular artery. Its course obviously goes behind the ear, as its name implies, and its position in your dissection to help you is just above the posterior belly of the digastric. That's usually where you see that branch coming off. Now let's take a look at the vagus nerve and its recurrent branches. To locate the vagus nerve, you want to relocate the common carotid artery. You've already taken away the internal jugular vein, or if not, you should do so, and expose within the carotid sheath between the vein and the artery a very large nerve that runs vertically down through the deep region of the neck. This is the vagus nerve. So its position is between internal jugular and common carotid towards the posterior side of the carotid sheath. As you trace that across the subclavian artery, the beginning of the subclavian artery, on the right side, you will see the nerve descend into the thorax and then have a branch, usually a large branch, just a little on the small side, that recurs or turns back into a superior direction. And it does so around the right subclavian artery. It will then head back towards the larynx, and a couple of important relationships as that nerve turns back superiorly. One is it lies between the trachea and the esophagus, which I don't think you can see very clearly here. But even more important is the relationship of that nerve as it goes back to the larynx to a vessel that I'm pointing to right here. This is the inferior thyroid artery. There's a cut branch of it here, but the main branch is continuing to the thyroid gland in a medial position. This artery has to be ligated when you remove a thyroid gland, and in ligating that artery you want to be careful that you don't also ligate and therefore interrupt the flow of nerve axons in the recurrent laryngeal nerve. This will obviously affect movements of the vocal cord. Okay, let me do some of the arterial branches right here that we're looking at from the subclavian artery. And one that you've already studied that descends into the thorax is the internal thoracic or internal mammary. This branch that ascends vertically is the thyrocervical trunk, and it has a branch that most of this artery turns medially to the thyroid gland, and you need to call that inferior thyroid branch. There is a small little branch that ascends in the neck coming off the thyrocervical trunk. This is the ascending cervical branch. And then continuing, in somewhat variable pattern, but continuing more laterally here is a branch that goes to the trapezius muscle, back towards the trapezius muscle, and that is the transverse cervical artery. Should be another branch, and I'm not sure if we inadvertently cut that off here or whether this is a variation, but there's another artery that you usually see coursing laterally called the suprascapular artery. Important relationship for some of these arteries is the anterior scalene muscle. Let me just point that out again right here. If we're going to follow the vagus nerve superiorly, back up into the neck, and we want to locate two branches in the deep neck that are called external and internal branches of the superior laryngeal nerve. The external branch is a thin nerve, much slender than the, this is the external branch, much more slender than the internal branch, and the internal branch is right here. So if you can see both of those at the same time, these are the two branches, and I'll go through their relationship. So I'm going to pull them taut so you can see that they're converging towards each other. They're in a superior position. Okay. The internal branch is the slender one. That goes to a muscle called the cricothyroid muscle, and it parallels this artery called the superior thyroid artery. A little bit deep to it, but nevertheless it's a clinically relevant relationship. Again, for removing the thyroid gland, you clamp the superior thyroid artery. You want to be careful not to cut or clamp this nerve, external branch of the superior laryngeal nerve. So that's a motor branch. The large internal branch of the superior laryngeal nerve is right here. Its key relationship is it disappears from your view in this dissection directly behind a muscle that you can see that I'm outlining right here. And this muscle is the thyrohyoid muscle. This nerve pierces a membrane of the same name, and it goes into the larynx. It's a primary sensory nerve for the larynx and has a lot to do with the cough reflex that we'll study later. Those are the two branches off the vagus that are called the superior laryngeal nerve. Just to point out again, the hypoglossal nerve and its important relationship to the beginning of the occipital artery. And then finally in this dissection we're going to take a look at the sympathetic trunk in the neck, which we call the cervical sympathetic trunk. And you will note the continuity with the thoracic sympathetic trunk. The position of the sympathetic trunk in the neck is posterior to the carotid sheath. And so you'll need to go through all of the soft tissue or connective tissue comprising the carotid sheath to identify the sympathetic trunk. It can easily be mistaken for the vagus that I'm pulling taut and wiggling a little bit here because they're both vertically descending nerves in the neck, and when you get the carotid sheath off, they kind of look like they're sitting side by side. The distinctive feature on the sympathetic trunk, however, is the very large and prominent superior cervical sympathetic ganglion. This massive area of dark tissue up in here that actually extends up even further than what I'm able to show you. Try that. Yeah, that's a little bit better. This is all the large ganglion, a collection of postganglionic sympathetic cell bodies. And then the sympathetic trunk will continue inferiorly to be continuous with the thoracic sympathetic trunk. The last structure you're supposed to identify here is best seen if you go back to the thoracic cavity, the upper thoracic region, and you can see, if you dissect in deep, a massive ganglion that is connected to both the thoracic and the cervical sympathetic trunks, and this would be the stellate ganglion. I'm not sure you can see that very well, but just make sure that's another structure you need to identify